This is Sally Schessler, Director of Education for Allergy and Asthma Network, and it's my pleasure to welcome you to this month's webinar in our 2019 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. Our webinar series helps Allergy and Asthma Network live out our mission, and that mission is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. Gayle Higgins joins us today for today's webinar, and she'll be speaking about community health workers and their role as a part of the healthcare team. Gayle has been a registered nurse for 34 years, with 32 years specializing in pediatrics. She received her BSN from Drexel University and her MSN from Temple University. She has been a pediatric nurse practitioner for the past 16 years, with a focus on asthma and other pulmonary diseases. Gayle has been the sole provider for 2 asthma clinics, one associated with a section of pulmonology and the second clinic ensconced in a primary care clinic. During her time running the asthma clinics, she has been working with the Public Health Department of Philadelphia in the Healthy Homes, Healthy Kids program, and with GHHI developing local partnerships. She was also on the asthma committee for the School District of Philadelphia. Gayle has worked with community health workers for the past 10 years. They have influenced her practice and have opened her eyes to the importance of community health workers in the healthcare field. Gayle now works for a nonprofit organization that runs school-based health centers in 12 local schools in Philadelphia. She works in one of those clinics and is partnered with the City of Philadelphia Health Department with a new program, Room to Breathe, which will offer services to children with asthma throughout the city. Caring for children with asthma and improving their lives and their families' lives is Gayle's love, her dream, and her life. Gayle, thank you for being with us today and sharing your heart for asthma care.
You're welcome, Sally. Thank you for asking. Okay, so to all of you that are on the webinar today, thank you for attending. So we're going to talk about community health workers today, and I'm going to start with the history because I didn't know too much about the history, or really until I started working with community health workers, but it's really pretty interesting. So community health workers actually were first started in China, and it was called the Chinese Barefoot Doctor Program. It was initiated by the central government of China back in the 1950s, and mostly in rural villages where there was no doctor available. They had the people, again, they were not doctors, but they had the community health workers initially go through a type of medical education, and it was a short-term training ranging anywhere from 3 months to 12 months before returning to their villages to farm and to practice medicine. They didn't practice like primary care medicine, but they focused on prevention rather than cures, and they also lived in the communities that they served. They were also combining Western and traditional medicines to educate people and to provide basic treatment. And as we go on throughout the webinar today, you will see that this continues on up till nowadays. So by the 1960s, China had institutionalized community health workers nationwide. And then by the 1970s, community health workers became a rallying voice of the American Public Health Association, and they actually have a section that is just dedicated to the community health worker. In the 1980s, the MHP Salud came into being in Texas, Florida, and the Midwest, and they were working with farm workers who were working on the farms in those states, because of course you can imagine they had no access to medical care. And they started MHP Salud with a small grant from the Department of Health and Human Services. Then come in 2007, the HRSA provided a comprehensive report on the community health worker workforce, which was found to be seen as a cost-effective way to address health concerns in underserved communities. So you can see the underserved communities started all the way back with the Chinese Barefoot Doctor Program, and it just sort of continued onwards until today. Oops, sorry about that. And it continues. In 2010, the Bureau of Labor Statistics assigned an occupational code to community health workers, so they were identified as an important component in the healthcare workforce. But you still didn't hear a whole lot about them. Again, in 2010, more funding was available for these groups, for groups that wanted to start a community health worker-led program. But the biggest and most exciting thing happened in July of 2013 when a CMS rule was passed that would allow payment for non-licensed personnel, which are community health workers because they are not licensed, could be paid for their work if it was recommended by a licensed practitioner. But unfortunately, the decision was left to each state to put into practice, which made it difficult because not all states took it up to put that into practice. I worked in the state of Pennsylvania, and they did, but it was still not real clear exactly what they could do. In 2014, the Center for Disease Control published the Policy Evidence Assessment Report on the policy component of community health workers. So more and more government agencies are starting to realize how important community health workers are. So today we have about 116,000 employed community health workers, and that's from the Bureau of Labor Statistics. States are now looking to develop standardized operating procedures or certification guidelines, but we're going to get into that in a minute. And there are multiple community health worker programs throughout the U.S., but certification is still a contentious issue, and you will see why that is a contentious issue. And that's been a bone of contention for quite a while. So when we talk about community health worker education, you can see on this slide that training varies from state to state. It depends what state you're in, what kind of training that you're going to have, and what kind of training is available. Community health workers need basic training on health, the community, but they also need specialized training for the disease that they will be working with, be it cancer, be it diabetes, be it asthma, COPD, just general primary care. They need to know what they're going to be educating people on. They need to know how to work with people. They need to know how to work with insurance companies, how to work with healthcare providers. There's a lot of training that needs to be done, and it is being done, sometimes through, like I said, standardized program, and sometimes just doing supervision with other community health workers and, you know, doing it that way. Certification programs are available, but the big question is, are they needed? People are afraid that it's going to scare away the people, and you're like, why would that scare away people? And we'll get to that in a minute. But at this time, there is no national certification program. Some states do have certifications that they require for their community health workers in those states, but I think at this time there's only about 16 states that require a certification. And continued training is recommended for these community health workers. When I had worked with my community health workers, we were always going to other trainings, myself included, to learn what they were learning, and it really, really helps. And the biggest contentious point is many people who are supervising the community health workers and that are working with community health worker groups feel that overeducation could be a problem and deter the candidates from applying for a community health worker position. When we say overeducation, I'm stepping ahead of myself. But when you say overeducation, it's not that you don't want them to be too educated. You want them to be educated, but you want them to be able to work with the families that they're going to be working with, and we'll get to that in a minute. Usually at this point I say, how many people have ever worked with community health workers? And, you know, a few hands will go up, and now my hand's going up. But I wish I could see how many people of you have actually worked with community health workers. So this is what a community health worker should be. This is probably the most important part of a community health worker, besides the education, is a community health worker should be a member of the community in which they will be working. It doesn't mean they have to live there at the time they're going to be working with that community, but they should have been a part of that community at some time during their life. They need to have knowledge about the community culture and the languages that are spoken. That is so important. They need to have personality traits that encourage trust and respect with the people of that community. You could see somebody who's, I went to my community health worker certification and I can do this and I can do that and I can do that. Is that the person that you want working with these families who have trouble trusting people and trouble, understanding? You would prefer to have community health workers have some previous experience providing some kind of health care, whether it be working in a doctor's office, working in a clinic, working, even volunteering. But that isn't a necessity, but it's something that you would like to have. Have a close understanding or share the ethnicity and language of the community. For instance, as we had a community health worker who was Latina. She did speak some Spanish, but she didn't do it on a regular basis. When she began working for us, we said, hey, look, you're going to be seeing a lot of Latino families, and we need you to speak Spanish. And she did. She just jumped in both feet and kaboom. She took off without a problem with being able to speak and also help translate for us. Share the socioeconomic status or have been in that socioeconomic status. Again, that's very important so these community health workers will know what these families are going through, and to share the life experiences of the community. Again, by somebody coming into the community who's had those similar experiences, these people will feel more comfortable with them. They won't be afraid to share with them. So this is just sort of a reiteration from the last slide. So a community health worker is a frontline public health worker. They're out in the community. They're who the families are seeing. They are the first person the family's going to see and the family's going to contact when there's an issue. We want them to be a community member, a trusted member of the community being served. Like I said previously, they don't have to live in that community as of that time, because sometimes that can be sort of dicey, but they know that community. They're familiar with that community. The community health worker, and this is one of their biggest things, is they are a liaison, a link, or an intermediary between healthcare and social services. If you have somebody whose first language isn't English, or maybe has a developmental disability, a learning issue, is illiterate, how can they get through and maneuver through the healthcare system we have today, or even social services system? This is where the community health worker really comes in as the liaison or the link between healthcare and social services. They can translate what is going on or what the doctor or the social worker is saying to the family and help them understand what is going on. They also are a facilitator. They're facilitating access to services and improving the quality and cultural competence of service delivery. Community health workers can help families make appointments for the family members who need to be seen, say, by a specialist or even a primary care provider. And they can attend those visits with this person to help them understand what's going on and what's being told to them during that visit. Because that's where a lot of things are lost. Somebody can go see the healthcare provider and they're saying, well, you're going to start on this new medicine and this is why, but does that family member understand what they're talking about? And last but not least, the community health worker is an educator. They're building individual and community capacity by increasing health knowledge. And by increasing that health knowledge for whatever they are having issues with, it empowers that family to stand up and say, hey, I can do this. I can take care of this. I used to see this a lot in my asthma clinic. The parent would come in and say, oh, Joey, his asthma was acting up a few weeks ago, but I did what you told me to do. And we didn't have to go to the emergency room. That's a big deal if they're able to control or manage something at home without having to go to the emergency room, without having to do something like that. It makes them feel so empowered and so good about themselves that they can take care of their child or family member. So CHWs, as you can see, they're around the world. They're also known as, they have lots of different names: community health workers, promotoras, and you will usually see that down in the Southwest and in California. They can also be known as health navigators. Some of them like to be called a health navigator rather than a community health worker. a patient navigator, and a lay health advisor. All these are basically the same kind of person. And like I just said, community health workers are found around the world. China, Iran, Brazil, lots of countries in Africa, United States, India, too many to be able to fit on a slide, but they are found around the world. So we're just sort of finally pulling them into our world here in the United States. So what do they do? What do community health workers do? Well, we know they work with families, and it can be families with children, families with elderly, with elderly family members who are having issues, even families of people who are middle-aged. But they work with families in general. And if there isn't a family, they will work with the patient, do a one-to-one with that patient, and be that support person for that patient, especially if they don't have family members or other support people to help out with them. They help families overcome obstacles that they face. We don't know what these families are facing because lots of times when they come into the doctor's office or the healthcare provider's office, they sort of look at us like, well, we're not really sure what you're going to do if I tell you something. So they may not tell us, but they're going to tell that community health worker. And then that community health worker can come and say, hey, this is what Mrs. So-and-so told me about what's going on, and I wanted you to know, but she was afraid to tell you. They're afraid that maybe we're going to call, in some kind of a, child and health family services and, take their child away from them or, say that they're doing something wrong. Community health workers can refer to outside agencies. This is a huge plus for these families. They have a litany of agencies in the cities where they work and in the counties where they work, where they can refer these families, you name it, furniture, food, clothing, transportation. They're able to help with these kinds of issues. They can, again, like I said before, they can help families understand what is going on with their child and family member. They're the link, they're the liaison. They can help translate what that healthcare provider is saying. Even the healthcare provider is thinking, well, I'm using low literacy, easy to understand healthcare terms, but maybe they're not. So they can translate what that healthcare provider is saying into words that that family will understand. They can help navigate the medical system. The medical system is absurdly difficult to navigate especially if you have diabetes or if you have asthma or if you need equipment or, there's multiple issues. And if you don't have somebody to help you, even somebody who's very well educated, has a college degree, could be a professional, they can have problems. Imagine a family or a family member who doesn't have any of that. That's what community health workers can do. They can help navigate the medical system. And they also act as a support system for the family. They're a trusted member of the medical team, and they can go to that person first and say, hey, what do I need to do? What can I do? Can the doctor help me? They're comfortable with the community health worker. They trust the community health worker. It's not to say that they don't trust the healthcare provider, but they may have just a little bit of, I'm not sure. So why are they so important? Because of this. So I put this kind of a picture up where community health workers are working with families, low income, urban areas, rural areas. They're working with farm workers. You can imagine, you hear about farm workers, housing conditions and everything. This is what community health workers are to help. Get them out of this or help them work to the best of their capabilities when they are in this type of situation. And I know this is sort of a scary picture, but this is what I see every day. And I'm sure many of you also do too. So the next thing I'm going to cover are health disparities. I'm sure that all of you are aware of health disparities, which is a lack of high quality education, a lack of nutritious food. A lot of these families live in food deserts. They don't have easy access to a grocery store. They have the mom and pop corner stores where you buy the junk food. They don't have access to fresh fruits and vegetables. They have a lack of decent and safe housing. And when I say a lack of decent and safe housing, there's mold, there's mildew, there's holes in the roof, or it's a violent neighborhood. Lack of affordable, reliable public transportation. Many of my families in the past did not have money for bus fare to get home from coming for a sick visit. What do? Lack of culturally sensitive healthcare providers. Lack of health insurance. I'm seeing that now where I work. And lack of clean water and non-polluted air. And all of these can be found anywhere within the world. And the next thing that you hear about all the time now are the social determinants of health, which are affecting our ability to remain healthy, for families to be healthy. If we don't have access to this, we're not going to stay healthy. So our social determinants of health, do we have the availability of resources to meet daily needs? You want to make sure that there are resources available for these families, that they have access to educational, economic, and job opportunities, that they have access to healthcare services. That's a huge problem in the rural areas. There may not be a doctor for an hour's drive away, and if they have no transportation, how do they do it? How do they get to the doctor? There needs to be an availability of community-based resources. There needs to be transportation options, public safety, social support, language and literacy, especially if we have a lot of families living in the United States that English is not their first language. And if they may understand English, they may speak English. Can they read English? Do they understand written English? If not, we need to make sure that we give them materials in their first language. If you don't, they're not going to understand anything. So these are all things that you need to look at when you're caring for a family. So why does this matter to healthcare? When we talked about the health disparities, can you imagine caring for a family who's got all those issues going on? It's very difficult. But if we don't take care of these issues and we don't make sure that the social determinants of health are met, we're not going to have a healthy community. We're not going to have a healthy United States. That's why this matters to healthcare. So I'm putting you in my shoes now. This is what I would pretty much deal with every day in my clinics, and I'm sure a lot of you probably are dealing with this too. So imagine that you're a parent or you're a family, whether you're the head of the family or you have a senior citizen. I'm talking from a pediatric point of view. So imagine you're a parent. You don't have enough money for food. You don't have enough money for the bus. You're not able to get to the pharmacy to get medications. You're worried about paying the rent. You're worried about paying for heat. The cold weather's coming. You have no family members who live nearby. You have no social support in where you live. You have no health insurance. And who knows what else. So that's just sort of the icing, think about it, the icing on the cake. So imagine not having any of these, having all of these issues when you're seeing a provider. And as providers, it's not something that you normally think about, but this is something that we have to think about now. And then throw in that your child has asthma. I'm going to go back to that previous slide. So imagine you've got not enough money for food, not enough money for the bus, can't get to the drugstore, you're worried about paying the rent, you're worried about paying for heat, you have no family or social support nearby, you have no health insurance, and your child has asthma. So take all of those issues, and then you're worrying about, do I have his medicine? Can he breathe? Will he be safe at school? Can I go to work if he's sick? Does he need to go to the emergency room? How do I know he needs to go to the emergency room? Can I find someone to watch him so I can go to work and not lose a day's pay? Why does he always get sick? What can I do to stop this? This is where the community health worker comes in. Because unless you can take care of all of those issues, the asthma is going to stay at the bottom of the pile. So if you think about your medical visits today, they're very short, very quick, very fast. Medicine is a money making business now. It's like They want you to see patients in 15 minutes. There's really no time for any kind of education during the office visit. This is going for an asthma visit. Somebody may stop in for 5 minutes to review spacer use for your child who is using a spacer and probably not doing it correctly. You have no time for questions, or you're so nervous because it's such a quick visit that you don't know how to ask those questions, or you're given new prescriptions, but no one's telling you what these prescriptions are for. And then, do I have the money to buy the medicine? And then, oh, I forgot to bring my bus tokens, or I forgot to bring money. How do I get home from this doctor's visit if it's not within walking distance? So these are all issues that these families are dealing with every day. So who can help? And this is how these parents, it's just everything is overwhelming. They don't know which way to go. They don't know how to approach anything. So who can help us, or who can help these families? Enter the community health worker. They are the community health worker is like Superman, Superwoman. They are coming to the rescue, not to make everything all better in one fell swoop. Like, Superman comes in, or Batman, and they get rid of the bad guy. They teach the families how to work through these problems and how to make themselves feel better and able. So it's an educational process. So again, this is sort of a reinforcement or a review what we had said before, but who are these community health workers? Like I said before, they're a trusted member of the community. They are a member of the health care team. They have knowledge of the communities they serve, and they are culturally sensitive. We had lots of families in my last clinic from different countries in Africa, and we were just noticing different cultural issues that were coming up, especially with the male or with the boys in the family, how the mother wouldn't make them take their asthma medication or wouldn't get mad at them if they weren't doing what they were supposed to do. So you start to notice these things, and then you're going to start saying, hey, well, what's going on? And then you're going to start, educating yourself about why this is, and hopefully be able to work with the families and stay culturally sensitive to what they've been brought up with in their beliefs, but teach them how to work within those beliefs to care for their child the correct way. So why asthma? Why did we pick asthma? Well, it's because asthma is the #1 chronic childhood disease. Cost for caring for asthma is over $86 billion a year. Let that sink in, $86 billion a year. It's a lot of money. We're seeing higher percentages of children living in low-income urban environments. As you saw before, there's many obstacles in caring for a child with asthma. And obstacles in caring for a child with asthma is not just in the low-income urban communities. It's also in the wealthy communities. They're not getting the education that they require, that they need. Because the healthcare provider does not have the time to spend with the family, we're all under the gun. We have to see so many patients in so many hours. Otherwise, we get dinged. And education is a must for any disease process, but especially with asthma. And last but not least, and I found this out 10 years ago when I first started working with community health workers, is a home assessment is needed for families with a child with asthma. So needed. So here we go. I love this quote. So this is food for thought. Now just think of what we talked about the home assessment. So Florence Nightingale had said, the connection between health and the dwelling of the population is one of the most important that exist. And if you think about that, it's sort of like, wow. And this was back in the 1800s, and now we're in 2019, and finally agencies, insurance companies, government agencies are realizing that, yes, we need to fix the dwelling where these families are living, because this is what's making their asthma so bad. So what does the community health worker do? And especially if the environment is so important, what do? They connect the dots. and we're going to get to all those dots. But there's you can imagine there's lots of little dots, lots of little pieces out there that they will just sort of start with the family, then go with them to the appointment with the healthcare provider, through the home assessment, and on and on and on, till we get things together. So for the healthcare provider, for those of you that are watching the webinar that are healthcare providers, community health workers are such a huge part of the healthcare team, and they do so much good work for you. So the community health worker will meet with the family at the visit. That's usually how it works, or they may meet with them in their hospital or in the emergency room, but they will meet them at the visit. It doesn't have to be when the healthcare provider's in the room doing the visit. They can meet with them after the visit. They will work with the family. They will go to the home and do a visit to assess the environment. If the child has to go to a specialist appointment, they can go with that family to that specialist appointment. They can arrange transportation for the family so they can get to the appointments, so they're not going 6 months between being seen and in the emergency room every month because they can't get to your office. And if the child is school age and having problems in school, they can go and work with the school to teach this sounds funny, but to teach the teachers how to keep a healthy classroom. And like I said before, they are the liaison between the family and the health care provider. Such an important tool for a health care provider and for these families. And what do they do for the family? Like I said before, they are a member of the community where the family lives, or they have lived there previously. They are non-threatening to the family. In the past, we've had a lot of families who weren't sure about letting a community health worker come to their home because they were afraid that they were going to get reported to the Division of Human Services in Philadelphia, or they were illegal immigrants and they were afraid that they were, going to bring ICE to the house. That's not what they do. They are there to help the family. They will help the family deal with the child's asthma. They'll do it through asthma education, going over the medications. They will assess the home environment. They will help the family work on the home environment. And lots of times there's a lot that needs to be done in these houses to get the environment up to par so that your child can live in that home safely. And they will help work with the landlords, and they can refer them to other organizations that can do work on the home. They will help arrange transportation, and most Medicaid insurance companies will pay for transportation for families who have difficulty getting back and forth to appointments. And the most important thing is the family knows that they have someone that they can work with, that they can trust, that they can call when there's an issue. And lots of times it may not be a medical issue that they're calling the community health worker about. It may be something as severe as somebody's threatening them, or they're getting an eviction notice, or their heat is going to be turned off in 3 days, or they have a gas leak in their house. All of these things, as a medical provider, yeah, we can sort of try to help take care of that, but the community health worker is out in the community and can lead them to the proper channels to get these things taken care of. So does it work? It absolutely does work. Studies have been done that shows a decrease in emergency room visits and an increase in school attendance. It shows an increase in follow-up visits to the healthcare provider. Ideally, asthmatics should be followed every 3 to 4 months to make sure their asthma is well controlled. Studies have shown an increase in compliance with asthma medications, and it's also a savings for the insurance company. Like I said, it's $86 billion a year to care for children and adults with asthma. So you can imagine if the education is done and they're not running to the emergency room, not being hospitalized, how much money that's saving that insurance company. And it makes for a happy family, as you can see in the picture there. So the two programs that I've worked with over the past 10 years, the first one was called Healthy Homes. It was a city-run program through the city of Philadelphia. And this was my first exposure to community health workers. We had two men who were both Latino. And we were able to refer families from the primary care clinic and the pulmonology clinic. And we had specific enrollment criteria, 2 emergency room visits or 1 hospitalization in the past year. They had income requirements that must have been met. They had to be on Medicaid, and they had to say that they were going to be living in the home for 12 months after repair. So this was a program that went in the house. The community health workers did a full home assessment, both for asthma triggers and for safety. We had biweekly phone calls with the team and the providers, and we saw amazing results. And it really opened our eyes as providers, because when I was in the section of pulmonology, you would say, how's everything at home? Any problems? Any this, any that? Oh no, everything's fine. Well, come to find out that one of the parents in one of our families was a hoarder. The child had no bedroom to sleep in, was sleeping on a sofa with animals. Another family, it turned out that, yes, we would see the mother, but the child didn't live with the mother. He lived with the grandparents. Things we had no idea about because they didn't tell us, but they told them. And I would have parents ask me, well, when is so-and-so going to call me? He said he was going to come out. And these community health workers, because they were from the community and that the families trusted them, that these community health workers could go in the home. And one time they went into a home with a child who had severe asthma. She was living with her grandparents. The house was filled with incense and scented candles and room air fresheners. And he just went through, took a trash bag, and just scooped everything that smelled in the home into the trash bag. And they were fine with it, but her asthma improved. So what we learned, like I just said, that the families listened to the CHWs, the families trusted the CHWs, and improvements in the child's and family's life were made. And like I said before, as providers, our eyes were open. Another issue that, as I said, that the families are afraid that, we're going to report them, to social services, for whatever some people think shouldn't be done. But the community health worker from the Healthy Homes, he had gone into a house that was a Latino family, and there were 16 people that lived in the house. And he was concerned that, should we report them, because there's so many people living in the house, but there was nothing, there was no abuse going on. It was a very lovely family that I knew well. So I finally asked the grandmother, who was the matriarch of the family, and it was their custom from where they came from in Puerto Rico, that it was a multi-generational, multi-family members live together, share the bills, share the rent, share the food. And so we told them this is their culture. This is what they do. So we also learned by things with that, by just the community health worker going in. So when it came to my asthma care clinic, I was the primary care provider. I had 2 community health workers. We were fortunate enough to have access to the medical legal partnership. We had access to social work. I had public health interns who were my lay asthma educators, and we also had nursing students. So we had quite a diverse, multidisciplinary team to work with our families with asthma. So our goals of asthma care within the clinic, that every child with asthma was going to be healthy and active, that these kids wanted to play sports. The parents were afraid to let them play sports, so we had to do a lot of education to tell them that, yes, your child can play sports. We want them to play sports. And education needs to be a standard of care for children and adults with asthma. Home visits were a routine part of the asthma care in our clinic. And the CHWs were a member of the asthma care team. They were there in the clinic when families came in, and they would meet with them in the clinic if they had to. And our ultimate goal was that families would not have obstacles in the way of caring for a family member with asthma. So you can imagine the few slides back when they had all those things going on and worried about their child's asthma. Well, we were able to work with the family to get rid of those issues, or put them on a slow burn, that we could, deal with them slowly but surely. And they were able to focus on their child's asthma and get their child healthy to the point that he was active. And that was all with the help of the community health worker. So Each CHW saw patients for specific Medicaid insurance, which was the only drawback, is I only had two, and we can only see families or children who had those two specific Medicaid insurances. But they were available to families 5 days a week during business hours. The families I cared for knew that I was in clinic every day, that if they needed to get in touch with me and they had a community health worker, they would call that community health worker, and that community health worker would come to me if it was an urgent matter, like if the child was sick. They met with families during the clinic visits. They also met with families when the family was in the hospital or in the emergency room if they were able to get over there. They did home visits, the initial home visit, and then weekly or biweekly home visits for the first month, then as needed. Some of them had up to 9 home visits because there were so many things going on. And they were able to refer them to community resources as necessary. And when I say refer to community resources, we're talking about help for heat, help for repairs to heating, to get heat in the house, clothing, furniture, food, and the list just goes on and on. So the results for one of our Medicaid insurances was we saw a 75% drop in emergency room visits in 1 year's time after they were, as I put it in parentheses, touched, in quotes, touched by the CHW, a 75% drop in hospitalization in 1 year's time after being touched, and a 43% drop in no-shows to the clinic after being touched by the CHW. So you can see that it really does work. The families were very pleased with how well the child was doing. They were eager to learn more about caring for their child with asthma. Their children were going to school, they were learning, and they weren't afraid to tell the community health worker if something was wrong. They trusted that community health worker. They knew that the community health worker was there to help them. They weren't afraid of backlash from the medical community, and that backlash would be, being reported for neglect, or, if they were illegal immigrants, which we had. They weren't afraid of being reported to child services, and which were things, and, there were probably other things that were going on in the home that were illegal that we not always saw, but they could have, whether a family member was out dealing drugs or whatever. This is the type of community we lived in, so we had to work around all of this. But after the community health workers worked with the families, the parents felt good about themselves. Like I said before, they were empowered and were able to care for their child's asthma and keep their children in school and out of the hospital in the emergency room. So what does this tell us? It says that community health workers are here to stay, that they work, it helps the families become healthier, and they help empower the families by providing education and support. And again, this is not, this doesn't deal just with asthma. This can deal with any type of health issue that's going on. But they just need that extra support, and that's what the community health worker does. And I like to always end my talks with, it takes a village to raise a child with asthma. And thank you very much for joining us on the webinar today.
Oh, thank you, Gayle, so much. We do have some questions for you.
Okay.
One is, I am curious how patients are told about community healthcare workers. I don't ever remember anyone telling me this was an option of support. Before we would send a community health worker in, and if I was seeing a family who had issues, and I'm like, oh my God, they really need help, I would go in and say, we have a program that with community health workers, there's somebody that can work with you, help you out with different issues. They can come into your house, do an environmental assessment, hook you up. So I would do it initially before I would send the community health worker in. And once you had that initial, and I said, they can come and meet with you right now if you have time. And it was as easy as that. Okay.
And then there were a couple times we had families who were like, well, I don't want anybody coming to my house. So then we were able to set up visits like at a local restaurant or McDonald's or, KFC, stuff like that, because there may have been something funky going on at the house at that time. But yeah, it's just sort of the way that you present it, that they're here to help you and they're here to help us help you.
Oh, that's great. Somebody's sharing that Healthy Homes is coming to New York City, and they're excited about that.
That is awesome. Healthy Homes was the best thing we ever had.
Oh, great.
Best.
Okay, next question is, does the community health worker need parental consent to work with the school?
Yes and no. Well, yeah, they do. We would, if we had a parent who was saying their child was always getting sick in school, and I said, well, we can have our community health worker come in, they're like, oh, please go. So it was never an issue for the parent to go in. And then because I was on the asthma education committee for the school district, I was able to reach out to the school district and say, hey, we've got a child who's having major issues. So then they could go in. We would arrange it with the principal, and they would go in and meet with the classroom teacher and find out what was going on, and then they could see the classroom that the child was in.
Okay, great. Next question is, does one community health worker go to a home all by themselves?
Yes. Yes, they do. We always would make sure that they let somebody know where they're going, just in case. We've only had one issue, not that anything happened to her, but there was something going on outside while she was in the house, so she remained in the house until whatever was going on outside was taken care of. But they would always make sure they all had cell phones. That's a must. They must have a cell phone, and they must let their supervisor know where they're going and what time they're going.
Okay, sounds good. Okay, roughly how many visits does a community health worker do with each family, and how much is the cost per visit?
The cost per visit is going to be dependent on what the insurance company is going to pay. Probably it's about like $100 to $125 per visit. And for the Room to Breathe program that we're working on right now, it's 4 visits. It's of the initial visit, and then 3 more visits for different lessons like education, medications, home assessment, and then they follow up at 3 months, 6 months, 9 months, and 12 months. And a couple of those are phone calls. Within the asthma clinic, it was sort of dependent on how detailed the family's needs were and how needy they were and how sick the kids are. Because a lot of these kids were pretty sick when we first started working with them. So every case was different. We didn't have a specific set number of how many visits in my asthma clinic.
So is that cost borne by the family or by insurance?
It's all by insurance.
Okay.
The family bears no cost.
Wonderful. Okay, someone's asking, which evidence-based asthma education program do CHWs follow?
The Association for Asthma Educators has a CHW curriculum, which is excellent. That I've been doing that. Just spent a week in August traveling throughout Ohio to do it. But it's evidence-based. It was, oh God, I'm trying to think how long it's been out now. It's been a while. I guess about 7 years. But it's a well thought out, very basic, because we need to remember that most of these families probably have a very low health literacy level. And, do they understand? Can they read? You just need to make it very basic. Like when I was doing the training this summer, I said there's lots of good pictures in your book, your participant book that you had. And I said, pictures are worth 1,000 words. But yeah, the Association for Asthma Educators.
Okay. Here's the next question. Although a certification is not required in New York, are there optional certification programs that community health workers can take?
It's up to each state. So you have to go by the state. As I said before, there's 16 states. I can't think of them off the top of my head, but there's 16 states that do have certification. One of them is Massachusetts, but there are a lot of colleges throughout the United States that are offering community health worker programs. Not so much certification, but community health worker programs, and you come out, like saying that I've been trained, whatever. Okay. And then the MHP Salud also has a training.
Okay, here's the next question. So I'm in Brooklyn in New York City and work for a community partnership. We're a nonprofit organization and a community health worker, asthma educator, and do home visits. How can we bring resources to the patients we see and the communities we serve? We want to learn more.
Oh, that's a great question. This is going to sound silly, but start Googling. That's what I did. There's so much out there rather than reinvent the wheel. And you can get materials from the Allergy and Asthma Network. The EPA has materials. CDC has materials. There's a great book for low literacy book, not a lot of writing, lots of pictures, bright, colorful, lots of bullet points. And I can't think of the name of it, but it's a program in New York City, Children's Health Fund, I think it's called, that have it online for a great book for families and older kids for adults. And then also you can get kids information. Iggy and the Inhalers, they have stuff online and also videos on YouTube, which is those are great. The kids love them. I love them. The families like them. Nick Jr. has stuff on asthma. There's the best thing to do is just Google asthma educational materials and see which ones you think would work best with your families. And especially if you're in Brooklyn and if you have families with that English is not the first language, that's how I got all my materials in foreign languages, by Googling asthma action plan in Arabic or asthma action plan in Haitian Creole or, things like that. And it will come up with different organizations that have these materials in all different languages.
Sounds great. The same person just followed up and said, great webinar and lots of valuable information we will use to empower each other. And oh yes, we Google a lot. And
good.
It's probably my responsibility here to say that make sure you check out Allergy and Asthma Network resources. We've got a lot of things there that you can use, that you can download for free.
Mm-hmm.
And also, we not only have our website in English, but we do have our website in Spanish, and many of our resources are in Spanish as well. Well, Gayle, that's all the time we have for today. Thank you so much for joining us today.
Oh, you're welcome. It was my pleasure.
This is great. Okay, for our listeners, thank you for being with us today as well. And at this time, please download the handouts from your control panel. If you have any difficulties, please email us using the link in your emails. Please join us next month for our November webinar when Dr. Alan Meadows will present on inhaler innovation in history. What is the right choice for you? This webinar will air on Thursday, November 21st at 4 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page of our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We hope you have a great and a healthy day as we work to breathe better together.